In this animation, I'm going to explain to you regarding mitral valve prolapse, which is also called as floppy valve syndrome or Barlow syndrome. So let's knock some sense into the topic. During the phase of systole, when the left ventricle will be generating a tremendous amount of force to push blood into the aorta, there would also be stress on the mitral valve leaflets. Now, the bicuspid mitral valve leaflets are able to hold their position thanks to the infrastructure of chordae tendineae and papillary muscles which are attached on the undersurface of the valves. Due to this infrastructure, not a single drop of blood is ever gonna leak from our left ventricle to left atria in our entire lifetime. But in mitral valve prolapse, there is an undue bulging of the mitral valve leaflets into the left atria due to lax and loose chordae tendineae. I want you to imagine these chordae tendineae as rubber bands which are attached on the undersurface of the mitral valve, and due to the undue stretching of these chordae tendineae, there would be vibrations that would be set up that would result in an auscultatory finding by the name of mid-systolic click or clicks. I'll speak about mid-systolic click subsequently as well, but I don't want you to mix them up with ejection click, which is a normal auscultatory finding of opening of the aortic and the pulmonic valves. So after all, why are we worried about mitral valve prolapse? Well, that's because of two precise reasons. The first reason would be a defective coaptation of the valve leaflets, which gonna result in leakage of blood from LV to LA, and that could result in a murmur as well, which would be discussed subsequently. And secondly, the undue stretch on the chordae tendineae would be transmitted to the papillary muscles, and the ischemia of the subadjacent myocardium results in development of chest pain and even angina-like symptoms in these patients. Now, the worst case scenario in these patients could be that the chordae tendineae can snap, and this could result in an incompetent mitral valve, which will cause leakage of blood from left ventricle to left atria. This is not only going to cause structural damage to the left atria, but this would also cause the blood to back up into the pulmonary circulation. There would be a pulmonary venous hypertension and then subsequently a pulmonary edema, which could explain symptoms like orthopnea developing in these patients. So let us now enumerate the causes for development of mitral valve prolapse. In fact, the first one is going to be an idiopathic myxomatous degeneration of the valve. It could be related to connective tissue disorders like Marfan syndrome, osteogenesis imperfecta, or Ehlers-Danlos syndrome. In fact, the third one is important from exam perspective, autosomal dominant polycystic kidney disease. Yes, guys, in ADPKD, they love to ask about the extrarenal manifestations, and the cardiac association is the topic that we're studying, that is MVP. Other causes would be like straight back syndrome or ASD, that is atrial septal defect. Let's now talk about the clinical features. In fact, the first one would be, or the commonest presentation is asymptomatic. Looks funny, but yeah, initially, when there is no leakage of blood, when the manifestations are relatively on the milder side, there are no symptoms. But in the same patient, due to undue stretching of the chordae tendineae and ischemia in the papillary muscles, these same patients could subsequently develop chest pain. They could be developing palpitation and dizziness as well. In fact, as I explained earlier, if there is a snapping of the chordae tendineae, these patients could get a frank mitral regurgitation that could explain the pulmonary edema manifestations like orthopnea, which could be written as PND as well, that is paroxysmal nocturnal dyspnea. In fact, these patients, due to ischemia of the myocardium, could be having arrhythmias as well. One of the common rhythm disorders which is encountered in these patients, which you will answer as the most common one, is premature ventricular contractions. In fact, in the animation, you can see a normal sinus rhythm followed by a broad QRS complex. This is going to be again followed by NSR, normal sinus rhythm, and again a broad QRS complex. Now, why I'm worried about this broad QRS complex is because it's a premature ventricular contraction. And you see, first atria have to contract, then ventricles have to contract, because atria contribute 30% of filling of blood of the ventricles. If you are going to be having a premature ventricular contraction occurring alternatively, this is going to cause a weak pulse. This is going to cause dizziness in the patient, or in fact, sometimes pre-syncope and syncopal episodes as well. A lot of these patients of premature ventricular contractions could degenerate into a ventricular tachycardia. In fact, in these patients, even PSVT has been documented, and due to structural damage to the left atria, even atrial fibrillation can occur. The commonest sustained arrhythmia overall in clinical practice is, yes, atrial fibrillation, but in the exam, if they specifically mention mitral valve prolapse and they say which is the commonest rhythm disorder seen, your first answer is going to be premature ventricular contractions. We will now focus on the examination findings of these patients, where the first one is going to be mid-systolic click, which is due to the undue stretching of the chordae tendineae, and subsequently there would be a late systolic murmur due to defective coaptation of the valve leaflets. I would like you to listen to the murmur now. Do not mix this murmur with that of ejection systolic murmur or valvular aortic stenosis, and you can listen to the murmur now. I would now like you to pause this video, rewind, and then listen to the murmur, which is late systolic murmur versus ejection systolic murmur, so that you become thorough in picking them up in your patients in real time. The third examination finding would be effect of squatting versus standing on the duration of murmur of mitral valve prolapse. Well, on squatting, the murmur duration becomes relatively shorter, and on standing, the murmur duration becomes relatively longer. All I can say is if I'm squatting, my height will be lesser as compared to when I'm standing. So on a squatting, the murmur duration is shorter as compared to that on standing. That would be a quick hack to remember regarding the variation in the duration of the murmur with squatting versus standing. The investigational choice for diagnosis of this patient is a echocardiography, and remember the posterior leaflet is affected more commonly as compared to the anterior leaflet. If the posterior leaflet is affected, the murmur tends to radiate anteriorly to the base of the heart. But if it's the anterior leaflet that is affected, then the murmur tends to radiate to the axilla of the patient. That's fluid dynamics. But the bottom line is posterior leaflet is more commonly affected, and therefore the murmur radiates to the base of the heart is a more important information to be remembered. As far as the treatment of these patients are concerned, if they've already had an episode of infective endocarditis, then prophylaxis for the same needs to be given. We would also like to use beta blockers in these patients so that you can control the heart rate in these patients. So it's more of a symptomatic management that would be required for management of patients with mitral valve prolapse. However, if a patient of MVP degenerates into mitral regurgitation, then surgical repair must be done in the form of valvuloplasty so that you can prevent a deterioration of these patients, especially the left ventricular function and a development of a decompensated congestive heart failure. So these are the details that I would like you to remember for this topic. Keep learning, guys, new things every day. And the more you learn, the more important thing is knowledge is power. And as you become more wise, your performance will gradually start improving.